It's an honor for me to be a speaker in this distinguished, after these distinguished two speakers. And I wish all the best for Italy. And I wish Egypt will not face the same catastrophe that happened in Italy. But still, we are now having increased numbers, despite the fact they are a little bit low to your country, but still we are having increased number of cases every day. And we have a mortality of about 6 to 7%. When I choose this topic, I chosen some debates on antihypertensives, anti-anginal and heart failure drugs, anti-diabetics, non-steroidal, and then I will tell you about anticoagulation and what to do in a COVID patient and how to anticoagulate, and then the new antiviral, just a couple of slides. The antihypertensives, of course, it was been elegantly showed by Dr. Claudio now, but the claim started in Mars, which was actually a theoretical base. It has a theoretical base, it's not just a claim, because as it was shown by Dr. Claudio, that having ACE inhibition or ARB inhibition, then there will be overexpression of AC2. And since the virus works on AC2 receptors to enter the tissue cell, then having a lot of AC2 will expose the patient to more viral load and more viral infection. This is the theoretical basis, and this was what caused the rout in March. But actually, in circulation, it has been shown that increased AC2 expression might be really of benefit, because actually ACE2 is responsible for the health of the pulmonary tissue, and having more ACE2 means more receptors free from the virus, so more pulmonary protection. So maybe at the start, theoretically, you are exposing the patient for more ACE2 to be attacked by the virus, but at the late stages of pulmonary disease, having more ACE2 expressions will serve to help tissue salvage. It's not that very clear whether to use it as a treatment, but at least if you are using ACE inhibitors or ARBs, don't stop it. There was also a study I've seen using aerosols of AC2, just a decoy AC2 receptors, so the virus will catch the aerosol rather than catching the pulmonary cells. Still under trials, but we will hope for the best. The ESC position was very clear, as shown by Dr. Claudio. I will not go into it again, but the Council of Hypertension strongly recommend that physicians and patients should continue treatment with their usual antihypertensives. And we know that the base or the first step of treatment of hypertension is using ACE or ARB. So the recommendation by ESC, the Canadian, the American, all to stay on ACE inhibitors or ARBs during the treatment of hypertension. So at present, we cannot rule out that long-term intake of ACE or ARB may facilitate SARS entry into the virus infection. But what we surely know that staying on ACE inhibitors will definitely reduce mortality, as shown by Dr. Claudio. So the verdict is stay on ACE, don't stop ACE inhibitors. For anti-anginals and heart failure, as it was shown, the only concern or interaction was beta blockers. And there has been some cases of prolonged QT interval with beta blockers. You can see the whole list, mostly safe, used with caution with new oral anticoagulants, vitamin K antagonists, and some caution with beta blockers. And the main cause was the interaction with the drugs. You can see from this slide that the interaction was chloroquine with the beta blockers, although mild, but can use prolonged QT interval. And you can see also with the lopinavir and altinavir that has been shown by Dr. Lorenzo to be used in Italy, has some interactions, moderate interactions with beta blockers. And pengolimod and spinomyot, which are also experimental drugs, are also have shown beta blocker action. So the main issue is if you are fearing beta blockers for QT prolongation and you need really heart rate reduction, which is an essential management of hypertension, then evabragine might be a suitable add-on therapy to beta blockers in this situation. Don't increase the dose, just add evabragine, hoping to reduce the heart rate, and at the same time, there are no reports of QT prolongation with every. When it comes to anticoagulants, it's very interesting that we have seen a lot of data. The Anticoagulation Forum and Thrombosis Research has published a paper stating that the incidence of thrombotic complications of critically ill ICU with COVID is about 31%, which is a high percentage. And this occurs despite DVT prophylaxis, and predictors are age and coagulopathies. So in this very important study published in the Practice Update, it shows that anticoagulation therapy, when used properly, mainly with low molecular weight heparin, can really be associated with better prognosis in severe COVID-19 patients meeting the criteria of markedly elevated D-dimer. So using anticoagulation is well approved, and in some studies have shown to reduce mortality. And this is the proposed algorithm for use of anticoagulation. If you have mild symptoms, then all patients should receive prophylactic, for the usual prophylactic enoxaparin dose, which is 40 milligrams. If the patient are hospitalized with severe COVID, then we should do a D-dimer. If the D-dimer is below 10 milligram per liter, then we'll continue on the 40 milligrams once daily. But if it's more than 10, then we will do it more of a weight-based. So although once daily, but it will be weight-based. If 80 kilograms, we'll receive 80 milligrams. But if there is sudden unexplained drop in oxygen, or there is evidence of DVT, whether in the upper limbs or lower limbs, then you use the therapeutic doses of twice daily according to the body weight of enoxaparin. The British Thoracic Society made a possible approach to low molecular weight dosing, stating that standard risk patient and the creatinine clearance is more than 30, then we use enoxaparin 40 milligram once daily or dalteparin. We don't have actual dalteparin back home, so we're using enoxaparin. The high risk patients, then there will be an intermediate dose of low molecular weight heparin. That's enoxaparin 40 BID. This is another suggestion by the British, contrary to the other algorithm. And if you have a proven or suspected VTE, then you should use the usual full dose of anticoagulation, 1 milligram per kg twice daily. And this is the Mount Sinai algorithm with admitted patients with moderate or severe COVID with high risk of increased oxygen requirements. D-dimers are high, creatinine is high, CRP is high. If you have this, then you should admit the patient to ICU. And if he is admitted to ICU, you either give heparin drip or enoxaparin full dose, BID. But if the creatinine clearance is above 50 and there is no high-risk patient, then enoxaparin BID can be used. Or from the start, it's not a high risk, it's a low risk. So again, it will go to the British Thoracic Society recommendations of enoxaparin 40 milligram once daily. This is a big algorithm, but it shows the same, that in mild cases or non-hospitalized cases, 40 milligram per day. In cases with D-dimers, weight adjusted once daily. In case of evidence of DVT or high suspicions of pulmonary embolism, then we give a full dose. This goes the anticoagulants. The non-steroidal had the same issue like ACE and ARBs, in that it was shown that also anti-rheumatics, specifically the one we are using very, very often, which is the Prophyl, there has been around that non-steroidal anti-inflammatory drugs will definitely increase AC2. So it will go to the same track of AC2 expression drugs that you should use with caution. Could be a treatment later on, but we had a statement that anti-rheumatics with COVID will work like anti-cytokine storm drugs. There are some cytokine storm syndromes, like viral disease and inflammatory rheumatic orders, that non-steroidals can work. So they are justifiably used, should be used in anti-rheumatic drugs in both conditions, whether heavy viral infection or inflammatory rheumatic disorder. So there is no concerns on anti-rheumatics or non-steroidal inflammatory drugs in the use during the COVID period. For the anti-diabetics, it's very important because There are certain rules for antidiabetics during the COVID patients admitted. The general tips is insulin is the gold standard. You should use insulin once the patient is admitted to the hospital. You should avoid medications linked to dehydration or hypoglycemia. And at the same time, the main message, whether in hypertension or diabetes or dyslipidemia, is that properly treating the disease will definitely protect your patient. And it's well known that SGLT2 receptor inhibitors and GLP-1 receptor agonists, they all do control diabetes and at the same time as cardiovascular protection. Nevertheless, there has been some issues with these drugs, as I will show you. Insulin, no concerns. There are no human data to support poor outcome if used. So insulin is the gold standard. Metformin, no concerns. Sulfonylurea, the old drugs have no concerns with COVID. Once we get to the glitazones, the pioglitazone, there's a big concern on the pulmonary S2 receptors and on the cardiovascular complications as a whole. Liraglutide, which is a GLP-1 receptor agonist, theoretical risk of poor outcomes is there. There are no human data, but pulmonary S2 expression is also increased. So there are some concerns on the liraglutide, not yet confirmed on human beings. DPP-4 seems to be the right drug medically, or the right drug to be used for management of diabetes during this period, because they exert overall anti-inflammatory role, help offset the cytokine-mediated acute respiratory complications. So DPP-4 might have a role in treating diabetic patients during the COVID period. When it comes to SGLT2 inhibitors, which is the most commonly used now for cardiovascular protection, there are two concerns. The first is also increased S2 expression. The second concern is dehydration. And the third concern is an instance of diabetic ketoacidosis with these drugs during the COVID period or critically ill patients. So there is a very daring study going on right now, testing the use of SGLT2 inhibitors, specifically dapagliflozin, in the treatment of severely ill COVID patients. It's going on. We'll have the results maybe in a couple of weeks. But until then, I think insulin should be the right thing. Then we come to hydroxychloroquine, and remind me, Professor Khaled, to give a question to Lorenzo about hydroxychloroquine for protection of the cardiology team or the health care providers. There has been some suggestions that it can be used as prophylactic with 400 milligram twice daily first, and then 2 tablets every week for prophylactic against COVID infection by improving or modulating the immunity of the healthcare physicians. I don't know how true is it, and is it used in Italy or not, so I will leave this to the discussions. But there is a new study, maybe published a couple of weeks ago, on a New England journal, journal showing that hydroxychloroquine does not improve lymphopenia, does not reduce mortality, but at the same time increase escalation to respiratory failure. So it seems there are too many concerns about hydroxychloroquine use, at least at the moment. In Brazil, the trial maybe 2 weeks ago was stopped early because of cardiac complication in COVID-19 patients. There are too many concerns regarding hydroxychloroquine and chloroquine. Favipiravir maybe is I don't know, there is an opportunity for this drug. It's manufactured in Japan, called Avigan, and it has approved trials, and it's going now to phase 3 trials for treatment of COVID-19 patients in Japan, and actually in Egypt and South Africa. There are, and India, I think. I'm sorry, India and Egypt. Egypt now, 50 patients are involved in a study to evaluate its benefit. We hope, we are searching, we don't know, but we hope it will work somehow. My feeling is that, like the H1N1, when you use the Tamiflu, is when you start very early in the disease, you could have results. But unfortunately, most of these drugs are used in severely ill, late-coming patients. But if they are used early, I don't know. We need a study about that. Then the remdesivir, which is finally approved last week by the FDA, Of course, only the main benefit was reduction of hospital stay from 15 days to 11, which to me is not really an achievement. But there was a numerical 3% reduction in mortality, which might give a hint that this drug could be really useful in treatment of such patients if given in a reasonable price. There are a lot of experimental drugs to be used, but I think these two drugs, favipiravir and remdesivir, could be our opening chance. We are here in Egypt having some suggestions for protection, like the BCG vaccine, like the hydroxychloroquine prophylactic doses, like anti-lice drugs. We don't know. We are using everything for the healthcare professional because they are the frontliners and they should be well prevented, well protected, rather than left to high load of viral infection. I hope I have shed lights on the current controversies in drug treatment during the COVID period. And I thank again Dr. Khalid Shukri and thank Servier Company. And I thank again Dr. Lorenzo and Dr. Claudio for accepting to share this very important session. And I think we will go to Dr. Khalid now for this question. Thank you. Well, I read a recent article stating that the prognosis is equivalent to the platelet figures, and those having platelets below 100,000 are at high risk of complications. And that's why a dual antiplatelet at that time is not that recommended, because the platelet function is important in these situations.